دكتور زياد حبيبي
Recording stopped.
ايوه صباح الخير. احنا معاك من القاهره هنا في المتحف الهيستوريك بتاع القوات الجويه، ومعانا الاستاذ الدكتور عادل الأتريبي، الاستاذ الدكتور أمين فؤاد، الدكتور وليد ضوي، يعني محمد صحيحه، الاستاذ الدكتور محمد غالي، كوكبه من الاساتذه جايين يشوفوا.
أول شيء أنا أرحب بكم أجمعين. I'm really I'm flattered and thrilled to be with this group of superstars, interventional cardiologists at the Egyptian Society of Interventional Cardiology, and I'm sure it's a great meeting. وحيي الجميع الحاضرين. As you know that SASIS have a long life partnership with Egypt, and we are very happy and proud to be with you. In addition to the Saudi Arabian Cardiac Intervention Society today, we have a new partnership with the Saudi Arabian Cardiac Surgical Saudi Society of Cardiac Surgery, and our two operators today, they are two eminent, Dr. Uthman Al-Uthman, and he's a cardiac surgeon. He's specialized in TAVI and in laparoscopic minimal invasive cardiac surgery, and at King Faisal Specialist Hospital, Jeddah, one of the well-respected cardiac center and one of the well-respected cardiac institute in the kingdom, and also Dr. Hinda Al-Asami. She's one of the leaders in women in cardiology, beside our talented woman intervention cardiology in Saudi Arabia. And I will let the floor for Dr. Uthman Al-Uthman to introduce his team and to start the case.
Assalamu alaikum, Dr. Wa'ad, do you hear us?
Yeah, we hear you, and I hear you.
We hear you also in Cairo. We hear you in Cairo also.
Good afternoon, everyone, and welcome to our first lab at King Faisal Specialist Hospital and the first center in Jeddah. First of all, I would like to thank the Egyptian Society of Cardiology, as well as the SASAS and Saudi Cardiac Surgery Society for this kind invitation. I have here with me my colleague, Dr. Uthman Al-Uthman, cardiac surgeon. We're going to be doing the case together. Let me just introduce my team. On my right is Dr. Aziz Al-Ramdi, our fellow. We're going to be doing the case today. We have also Amira, our sub nurse today. We have our radiographer, the district radiographer as well. We have also Bassam and Dua, our assistant nurses. We learned that we can see the team because we learned first and Nadina. And can we go ahead and start with the case presentation?
Yes, go ahead, please.
Good morning, everybody. I would like to present the case of a 66-year-old female patient independent at home with background of severe aortic stenosis, with hypertension, morbidly obese, hypothyroid, Parkinson's disease diagnosed in 2017 with limited mobility syndrome. She presents to our clinic with chest pain and exertion over the last 7 months, no shortness of breath or sympathy. Physically, body blood feel of obese with body mass index and measured body of 41. Blood pressure and heart rate, all vitals within normal, saturated air 97%, no JDB distension, cardiovascular noted for ejection systolic minor related to carotid, chest is clear, and no lowering edema. Investigation of the remarkable, blood dose is 9.7, hemoglobin stable 12.4, CDFR remarkable LDO 1.7, hemoglobin A1 306. Confident to surgical risk is the S4 fever. Next, please. And here, the ECG, as you see, is normal sinusoid with narrow PRS complex normal duration. Next. And you can see the TTE, parasternal axis, the normal lifting to prediction fraction, calcified optic valve, and right dark axis, the optic valve, dilated stenotic optic valve. Next, please. I'm replacing the aortic valve and LVRT, which show maximum gradient was 74 and mean 46, Dmax 4.3, and calculated part area 0.7, which is meeting criteria of severe symptomatic stenosis. Next please. Anchored cardiology, which showed non-obstructive coronary disease. Next. Case have been discussed in RT meeting and collectively determined that TAVI is a preferred approach over SAVI due to heredity and neurological disease, this Parkinson's disease. Next.
So the intended procedure is TAVI, and I would like this to ask the panelists, what do you think based on what what presented so far? Is it reasonable to go for TAVI, and or what's your suggestion? Do we need to consult surgeon for this patient?
So Professor Abid Fouad will. Based on the general condition of the patients, you decided for TAVI. What is the rationale in Saudi Arabia? Is a threshold to do TAVI is high or low, or what is the common contraindications for surgery? Is just because she is morbidly obese, or because the condition, or because the patient's preference for them? What is the case in Saudi Arabia? Please.
So I will refer this question to the operating team, and guys, what is the threshold for TAVI? I will frame the question. If you have a 65-year-old, relatively healthy, what is your, most likely your heart team will decide, surgery or TAVI?
So if we are talking about this particular case, in this case, she is morbidly obese with BMI 31. She is frail. She doesn't do much for the last 7 years since she was diagnosed with the cancer. She's frail. And the main concern was the cancer, and that is the main concern for surgeon. Maybe Dr. Asman can comment on that as well.
Good afternoon or good morning, Cairo and Dr. Wahid and Professor Amin and everyone. It's an ultimate pleasure and privilege to be here and to conduct this case. Back to the indication in this kind of patients. In Saudi, our preference work in all times is heart team discussion and look at the patient from all perspectives. When you published guidelines, that was consensus between among all the interventional, non-interventional, and cardiac surgeons and all the people in the field of cardiology. We had a lot of discussion about this. So in the guidelines, 65, this is the gray zone, really, between surgery or no surgery. Particularly for this patient, definitely she's a higher risk that was not captured in the guidelines, like the Parkinson's disease and the frailty. But the frailty now is starting to be one of the areas that have a lot of hard discussion to be involved. So in Saudi Arabia, we can do TAVI for patients according to their wishes. We advise for the best interest of the patient and for better outcome.
Is it her coronaries was normal or some disease? Mild.
We had just mild cardiac disease, but not really neurology.
The coronary angiogram was done. It was more coronary disease. We're not able to pull it up here, or we're not some glitch in the.
Unfortunately, we don't have the images right now.
Yeah, so the coronary is normal, and patient with several comorbidities, it's extremely reasonable here to go for TAVI. So what is your, if you allow me, Dr. Ahmed, to ask them, what is your platform you want to use today, and to take us a tour throughout what you have done so far. We need to know all about the CT, if you don't mind, to complete the picture.
Let's go over the CT analysis. So as you see, do you see the image of the CT at your side? So as you see here, her aortic valve NS measures, aortic valve NS perimeter was around 7 to 1, and then the Eglc with a little bit measured 72.2. Next. You can appreciate that moderate amount of calcification on the device. And when it comes to the coronary heart, we have no issues with the left coronary artery measure 11, almost 12, and the right coronary artery measure 13. The only issue in this particular patient was border venous sinuses, with average of 27. The ST height was around 20. So the next piece. When it comes to femoral, there is lots of no effort. It looks like clean, but we prefer to go right femoral artery, and the left has a little bit high bifurcation. So in terms of left side in this particular case, we elected to go for the minimum self-expandable valve. Next. So based on our measurement, the first level in 26 millimeter is a root. So we're going to use today root XX. I think she test at 26 millimeter with 50% of the target. We could also have used 29, but the alternate X on this case is more targeted. So for 29 above the at least we will need the 29 of Cardiology Galba, but in this case our average is 27.
Very good.
Okay.
So, any comment from the audience and the panelists? So, what do you think, 26 or 29?
I will vote. Hello, سعادة الاتريبيتور.
يا مرحبا بروفيسور. يا مرحبا.
I will vote for 26. I would rather put.
It's a reasonable oversizing. We need 10 to 15%, and as Dr. Hind illustrated nicely, that the sinus valve is a bit narrow here, so we don't want to include that. So it's very important things to when you read the report, you have to look carefully at the level of the coronary artery and the height of the sinus valve and the width of the sinus valve. This always we don't look at it carefully, but in this patient it's really mandatory because 29 will be really oversizing. So that's a nice illustration with the CT hand. Can you explain for us, please?
You see here we have the vertical valve. We use 26 on the left side of the screen and 29 on the right side of the screen. So if we concentrate on the left side, this is the 26 valve. You see that we're really discussed in terms of sinus valve. When you look at the right side of the screen, the 29 clearly appears to really the sinus cannot accommodate this size of the valve. So we elected to go for 26 FX.
What about the selection of this particular evolute approval? Is this little bit younger patient? Do you think to take another device, another valve, or you select this valve particularly for this patient?
So in this particular case, we really wanted to use a self-expandable valve so we can recapture in case any risk of chronic structure. That was the only one of the best advances over the balloon expandable valve. So for this reason, we really discussed this case extensively in terms of which platform we're going to go for. And since there was a risk of chronic obstruction, we elected to go for something that we can recapture and we can again use another valve.
So if you allow me also, this patient with too many comorbidities, you will figure out what is the too many comorbidities. So the survival rate in general is not as normal. One of the things you can argue is to get the best hemodynamic valve with late or small fraction of valve degeneration for younger patients. So here the level of the coronary side or the orifice of the coronary is high. So even if you want to do valve in such patient in the future, I don't think it will be a problem. Coronary access, with the commissural alignment, it became history. Now with commissural alignment, we can take up to 95 of the left side and up to 88% of the right side. So I'm not worried about the chronic, honestly, especially at chronic mild disease. So it's a great valve selection here. I would go also for Eglc, and I would go for 26. Any comment from the panelists and audience?
Yes, I just want to ask the operators how frequent they do cerebral protection in cases with neurological defects. This is one thing. And is it a routine pre-dilatation or a direct implantation of the valve? What's your routine procedure?
So with that, here the second question. So maybe Dr. Aslan can take over for the question.
Sure. So
Dr. Osman, we don't hear you very well. Can you do something about it? We don't hear you.
The
voice
is
is
down.
not clear.
now? Sorry. The protection devices, specifically for this person, there was not much classification, and I saw the time around the entrance and even in the valve itself. And the person was not that an issue big time. Other than that, we heard it was selected.
So what have you done so far? Did you start the case or what did you do?
So our strategy is to go for travel via American Femoral access using Eglc FX20 6 millimeters. We look enough to re-dilate in this case, which will not see the simply testified area of the negative range and there is not room for fusion. So we're going to deploy at the first overlap and Dr. Yael elevated earlier with commissioner alignment, just to give a better chance of primary engagement in the future given the age of the day. And the possibility of post-dilatation. Maybe I give a chance to Dr. Asman to walk us through what we have done so far.
So, the previous study with the volunteering, we did bunch of this routine through the time with continuous approach. We used the regular through and one femoral side in the device. But unfortunately, this will be both the regular artery was very tough to use, even in the previous angiogram. That's why we did both femoral arteries, we have to continuous approach. On the right side, we will go under the device. On the left side, we will do the picture. And at the same time, we use the loop for the temporary pacemaker. Now we do have the big tail already in the IV after crossing, and we shall proceed.
Any question from the audience or panelists?
Yeah.
So it was.
Yeah,
Go ahead. So Uthman, while you are doing the case, we're gonna discuss and talk with the panelists. Just focus on the case and go ahead with the talk.
Let me ask you, what are the cases now with better profile of the device that you need pre-dilatation as a must?
Yeah, so there is some platform that you have to, relatively you have to pre-dilate. For example, accurate, you will pre-dilate almost in every patient, except if there is no heavily calcification and it's non-rheumatic. Because remember, rheumatic is this fused commissure with fibrosis. If you don't pre-dilate, even if you undersize the balloon, it will be a problematic. So accurate, you pre-dilate. An aviator, you pre-dilate. The metropolic is a blend. If it is heavily calcified, then you pre-dilate. Yesterday we have done TAVI for 5,000 calcium score. This one definitely you have to pre-dilate, and 5,000. And the guy of Medtronic is sitting at the back. I saw him just now, Turki Barayan. He was scared that we're gonna we're gonna nail it. Don't worry. So it was a wonderful case. Yes, there is some mild paravalvular leak. We accept that, but no other platform can take 5,000 calcium without complication. All the balloon expandable, like Edward and Neval, you cannot go with this valve in heavily calcified valve.
So now they are proceeding with the
So after putting the pacemaker and they cross with a regular wire, they put the pigtail. Now within the pigtail they put the confida. This is a confida wire, Uthman, is it?
Correct. We use the confida wire in this case. Sometimes we use other wires like Safari, if there is a small LV or something like this, a small.
دكتور وائل معاك عميد طبيب وليد الدولي رئيس عامل ايه يا حبيبي؟
يا مرحبا سعادة العميد يا مرحبا.
هنستأذنك بس هنعمل شيفت دقيقتين على الكاس لاب في المستشفى الجوي نفاينل معاهم حالة سي تي او ونرجع نكمل معاك حالة
ايوه بس دكتور وليد لانه الان هم دي ارجون
بتدوس الباك اوكي يبقى نويت شويه يا دكتور معاك يا دكتور وائل
يعطونا بس 10 minutes يعني كده.
معاك يا دكتور وائل.
Can you have the data now?
Now, what we need to see, Dr. Ray, the level where you are going to deploy the valve is very important for us.
Yeah.
Because it is direct, you will not dilate, and so the level where you deploy is very important for the procedure.
Absolutely. If there is not too much calcium, I'm not worried about post-dilatation. If it is non-rheumatic, like such patient, but case with two comorbidities, I'm sure and there is no other evidence of rheumatic valvular involvement, so it's not rheumatic. And not heavily calcified, so it's a degenerative.
I notice it's surgical cut down, right? It's not.
Percutaneous.
No, it's not
It's percutaneous or surgical?
Yeah. So this Dr. Uthman is the only one in Saudi Arabia. He loves to use one tuberculosis. I use two tuberculosis. I don't know what he put today. It's one or two, but usually he use one tuberculosis.
That is cost effectiveness or
there is a lot of paper show that it's more safer and more same success rate with one tuberculosis.
Maybe with a vascular cardiac surgeon, he prefers a cut down rather than cheese, right?
Uthman, he don't cut. He's the super duper of laparoscopic surgeon and minimal invasive and laparoscopic surgeon in the kingdom. In fact, he's writing the consensus document now of the National Heart Center and SASIS and the surgical group in minimal invasive surgery. So can you focus on the angiogram, please? Focus on the angiogram. Don't show us the hands.
Can you see the curve, please?
yes.
Just show the curve.
We see it here. It's coming. And this
So
is
Dr. Uthman, try to have the commercial alignment as much as we can.
Dr. Hind, can you tell us which was the cast overlap view? Which was the best view?
The lab is IO 2026, further 26. This is basically how we can assure commercial alignment. So maybe Dr. Uthman can elaborate on this.
So we will leave the floor for you guys. You talk and you teach us.
Okay.
So what we see here is the hat that we see on the same valve, the Medtronic one, and what we see is on the ground here we see
the hands here.
the flush port. It will be a 3 o'clock. So now we are trying to position the valve and get the angle on the cusp overlap. Can you go to the cusp overlap, please?
This is the overlap. Okay. So
I need the
set it down. Can we have the standing here?
close it.
Standing, please. So maybe we're gonna advance a little bit more. If you can see, we're almost in plane.
And it's positive.
Yes.
We do one injection.
Okay, let's do an injection here.
I think.
Well, we will not tell our surgeons here, but this is a very good demonstration of the collaboration between surgeons and cardiologists. We will not.
It's not only surgeon cardiologists, it's two society together.
Yeah.
Uthman is representing the Saudi Society of Cardiac Surgery, a very active group, and they just finished with us writing the TABI guidelines. So SASIS, the Saudi Arabian Cardiac Intervention Society, is leading now in writing the guidelines and the consensus document to fine-tune the practice in Saudi Arabia and the Gulf and the entire region. So it is in collaboration also with some societies and bodies from the Europe and USA.
Next, please.
So this is the cusp overlap view, is it?
Yeah, so we have the customer overlap view here, and we will give one injection. We try to do the minimum as much as we can. We don't do a lot of injections. We just give the injection while we have the bath in place to make sure where we are standing, and then we'll go from there.
When we went to our customer lab that we were able to get through the CP, there was a little bit of burn. We had to add more powder to eliminate all the product, and you can see right now the Dr. Rahman physicians, they have more add the lower border of the exhale.
So what are the criteria you are satisfied with before you deploy the valve? What is this views?
So this is the cusp overlap. You basically isolate the foreign cusp by overlapping the right and left. And this is to assure the accurate ejection of the blood. So in this day, the members of the maybe we were not able, didn't show it earlier. The CT scan member second was around 7, and she had a normal time with now convex ECG. So really, the risk of pacemaker is low in this case. So even if you go like a little bit low, it will be acceptable. But for purpose of implantation, we align the
Yes.
so we
will start slowly here.
We align the half mark.
Yeah, it looked good. It looked good here, Uthman. It looked good. So there is 3 marker in the valve, Dr. Ahmed and the colleagues there.
Yeah.
The 3 marker is supposed to be on the annulus. So Uthman and Hind, they are using the broad technique. Broad technique is they start to release up to minimize the conduction abnormality here.
Yeah.
So now you can see now he's unsheathing.
To me, it looks a little bit higher than it should be.
No, it will die. It will die.
Sometimes
We start with the higher implant and then die.
Just focus on the angio, please. Focus on the angio, please. We don't need to see the hand.
So, doctor, so you are releasing partially the valve and then you advance a little bit distally for 2 to 3 millimeters afterwards?
No, it will die. It will die. You see now it
by
dies.
itself.
Or by itself during the deployment.
So that is during implantation when we try to open the valve, you can see the valve died in storage.
Actually,
Now you can see the
it
pin
dies
drops.
3 millimeters now, almost.
Yeah.
Yeah.
You can do a one test here, guys.
That's what I was asking about. Testing.
Great for me.
So it looks good in terms of different lines. Yes, we see it more deep on the left side, but this is gonna adjust itself with the release. Again, position and it's off.
That's amazing, guys.
This is nice. Very nice.
Yeah. So,
Then the part planner.
So you go to co-planner or you go LEO-codal, Uthman? Usually I go LEO-codal and in any LEO-codal I eliminate the parallax, like put the 3 dots on the same line, then I do the injection for the left. If it is not deep, I will be happy to release. You see now the orientation of the valve change, which is, you know, like the aorta is distortion, it's not straightforward. Yeah, try to go up and down to make the 3 dots together.
So now it's overlap with one side and we exit one on the left side.
Yeah.
We can check the top. Can we go to top line?
Go to pressure is good.
Yeah, that is fine. We have it in the and if you're looking at it, go more positive, go sir. More positive, more positive. More positive. Alright. More area. Area. More area. Area. More area, okay.